Welcome back, everybody, to the Hart2Heart Podcast. And my guest today is Andrew Holmes, and I'm really excited to chat with him. We're actually chatting before the show, and I think this is episode 177, and I've never done one really specifically on sleep. And Andrew is a sleep expert, so I'm really excited to chat with him today. So Andrew Holmes is the owner and founder of Sleep Efficency. It's actually a test I've taken before, which I'm certainly going to get into today. But Andrew, welcome to the show, brother.
Thank you for having me. It's a pleasure to be here. I think we got some good content to spread the good sleep gospel.
Yeah, I'm really excited to chat with you, like I just mentioned. But kind of before we start chatting about sleep and sleep apnea and all the different tools that you have at your disposal. Why don't we just get into a little bit of how did you get here? Like how did you why did you start Sleep Efficency?
Yeah, it's somewhat of an interesting story, I suppose. My career started about 20 years ago. I'm 47 years of age now. I've been in the field of sleep medicine for just over 20 years. I'm a registered sleep technologist. It's also known as an RPSGT, or a registered polysomnographic technologist. So there's ultrasound techs, there's X-ray techs, there's MRI techs, there's sleep technologists as well. So I started about 20 years ago at a hospital here. I'm physically located in Ottawa as a night technologist, a sleep technologist, doing 13 years of straight overnights, doing diagnostic and therapeutic studies. So, not ideal. The irony is there, we put you on overnights for the first 13 years, which is literally the worst thing they could possibly do to you, just for circadian rhythm and a whole variety of things. But I kind of evolved the role a lot more than what it was initially intended to be. After 13 years of straight overnights, I won the competitive process of senior of cardiopulmonary department at the Queensway Carleton Hospital here in Ottawa, where I was in charge of a team of about 55 or so. And we tested anything to do with the head, the heart, or the lungs. We did it. It was diagnostic outpatient testing. And the sleep lab was part of that. So I was kind of the senior sleep technologist for about a decade, kind of running the day-to-day operations. In 2015, I kind of founded Sleep Efficency, not really knowing exactly where I was going to take it, more of kind of a consulting business initially to start. I had a friend who was with the Air Canada Pilot Association, and I had gone on the CTV News quite a few times discussing the importance of sleep. And he said to me, have you ever thought about maybe opening up a consulting firm? Because we could actually use you in fatigue management with our pilots and these types of things. So Sleep Efficency was kind of born from that. We've evolved over the last 10 years. Our primary model is a home-based sleep testing device that we can talk about a little bit later. But yeah, we've processed over, I think it's still thousands of patients up to this point. We have over 300 doctors that refer to us on a regular basis. And I do a lot of consulting work still, working with the Ottawa Senators. A sleep consultant, go on CTV Morning Live as their sleep subject matter expert, done some stuff with the National. So yeah, I guess I can say, in closing, I've evolved the designation of an RPSGT, a sleep technologist, to be a lot more than what it was initially designed to do. I got out of the dark on those sleep lab nights, and I'm here today to have a chat about all things sleep, A to Z kind of thing.
Awesome. Yeah. Well, I think over the last maybe 5-10 years, but certainly over the last 5 years, I think whenever Matt Walker did that podcast with Joe Rogan, and then also just Andrew Huberman's podcast is blowing up. He's, chatted a lot about sleep. More and more people are interested in sleep and interested in how it affects their overall biology and physiology. And so, we know that it's important for energy, but we know that it's important for so many other things too. Like people have talked about like how it's good for, increasing your testosterone, increasing growth hormone, like these things, don't get the attention sometimes that they deserve. And, just by, improving your sleep, you can improve so many, parameters. And I know that, a lot of people are struggling out there with their sleep. And so, I kind of want to focus on, that today in terms of like diagnostics and what people can do. So, in terms of the tests that you do, like it seems that, and again, I've done the test myself, guys, and it is, a very, very easy test to do. But maybe you could just tell people, a little bit about the test, because a lot of people will, even though they have trouble sleeping, they sometimes can't get a referral or just too busy to, get a referral to a sleep clinic. And also too, they just find it, very cumbersome, and maybe it's not really even realistic or accurate if you're going to a sleep lab. I'm not saying the equipment's not accurate or anything like that. I'm just that, you're in a different environment. I mean, people don't sleep well sometimes in, beautiful hotel rooms, right? They just rather be in their own bed. And so maybe you can just chat a little bit about, the actual test itself that you guys do.
hmm and I'm in a good position to almost compare and contrast here. After working straight overnights for 13 years, I know what that sleep lab experience is, and it has its place. But you're right. There's overhead pages that are going all night long. It's you're waiting sometimes up to a year to get in there. You need a referral to get there. You've got people coming into the room, which is a small bed. It's not very conducive to and representative of a true night's sleep in many ways. Again, it is still kind of the gold standard, and it has its place. Home sleep testing is kind of evolved, and it offers an alternative. So essentially what we do is offer an alternative to that traditional approach. Wait times here in Ottawa and across the province of Ontario and in many parts of the country, you're waiting over a year to get a sleep test done. Whereas we have an ability to ship these devices directly to your home. You get to do the test in the comfort of your own bed. They're ideal for different populations, such as single parents, for instance. How is that parent going to stay away from their kids for the entire night if they have to go spend the night in a sleep lab? We have lots of patients that come through that have been suffering from PTSD. We work with Canadian Armed Forces. They,
Oh, wow.
even a door clicking can trigger an episode. So how are they supposed to spend the night in a hospital-based facility where overhead pages are going, alarms are ringing off? Just people with general anxiety. People don't like the idea of going to a hospital really for any purpose, let alone having to spend the night there. So our home-based sleep testing approach now, again, we're shipping right across the province. It arrives at your front door. We have the results in 48 hours. And people always ask me, what's the main difference between the hospital-based sleep test and the home-based sleep test? The hospital is really looking for 100 different types of sleep disorders. So if the indications are things like seizure activity or REM behavior disorder, where you act out in your dreams, periodic leg movements, these types of things, then the hospital might be a better approach for you because you've got a technologist watching you on camera all night long, which isn't creepy at all. But they've got eyes on you and they can actually keep an eye, and they're doing some video recording as well. What the home-based sleep testing purpose is really looking to dig deep into any type of sleep disordered breathing, anything that falls under that sleep apnea umbrella. We calculate what we call an AHI, which is an apnea hypopnea index. We capture an RDI, which is a respiratory disturbance index. We're looking at oxygen levels across the night. We're looking at heart rate. We're looking at body position. We're looking at different sleep stages, which is actually something relatively new to the home sleep testing field. Once upon a time, you weren't able to capture that because you needed a variety of different EEG electrodes attached to your head to be able to capture those sleep
just
cycles.
maybe, like, I was kind of surprised at how easy it was in terms of the equipment. Like, all you need to do is just attach something to your finger. Like, there's nothing going on your head. There's no electrodes. Like, it's literally just something that's going on your finger. It's like similar to like what takes when someone's measuring your oxygen. Like,
Yeah.
that's essentially what the test is, which I found to be extremely convenient.
For sure. There's a little chest nodule piece, if you remember, as well, that kind of goes up
Right,
at the
right. The
top of the
chest nodule
thoracic
piece.
bone.
Right,
But again,
right.
very minimalistic. And what's amazing, Mike, is as our technology advances, so does our healthcare. Sleep was once looked upon as this dormant period where we didn't really know why it had to happen, but it happened every single night. It was a non-negotiable. And only since it's a relatively new field of study, only since maybe the late 50s or early 60s did we realize there was a lot more going on when we slept than what was once thought. It was just known to be this blackout period. Late 50s, early 60s, you had these first EEG tests, electroencephalogram, where they noticed that what was happening to the different brainwaves that they were capturing on these recordings were changing over the course of about a 90-minute period, which has now been born into a sleep cycle. So the size of the brainwave was changing, the speed of the brainwave was changing, the amplitude. All of these things were taking different shapes and forms and different characteristics. And out of that, they realized, there's a lot more happening here at nighttime, and hence where the sleep cycle has come from, and maybe even segueing into, what do all these different stages of sleep really offer? Because each one of them is slightly different. But again, a 90-minute kind of repetitive process.
And in terms of, like, we're talking about now, the different types of sleep that people get. So, total sleep is what most people know and refer to. And, people say, try to get 8 hours a night or, 7 hours a night. Usually somewhere between 7 and 9 is the recommendation, but probably 8 is probably the number that's, generally thrown out there the most. But there's also REM sleep and there's deep sleep. And something I've only learned, probably in the last like year or two, and I'm, kind of almost embarrassed and ashamed to say that, is like your REM sleep, I guess that's like where you really process a lot of your emotions, and it's going to be helpful for, emotional regulation the next day. And then with your deep sleep, that's where you're going to get, what I was mentioning earlier about like the growth hormone and testosterone output, and then your, restorative stage of sleep. And so, when people are doing these sleep studies, like, do you find that they're kind of shocked at how maybe little REM and how many little deep sleep they get? And then, oh, like this kind of makes sense. I'm not getting, very much REM sleep. I have noticed that, I haven't been in the greatest mood lately, or I have noticed that, my emotional regulation hasn't been, where it was. And then, the same thing with like deep sleep, like, yeah, I have noticed that, my testosterone seems to be lower, like my libido and my recovery from workouts and things like that. So, are people kind of very surprised? And I do want to chat about, sleep apnea, obviously, but, just in terms of like those two particular stages of sleep, like the REM and the deep, maybe if you can just chat about that a little bit.
For sure. That's like the meat and potatoes of your sleep, right? That's that sleep that really affords those symptomatic improvements. So deep sleep, it used to be known as stages 3 and 4, or slow wave sleep. And these are the types of brain waves that have massive amplitude. If you're looking on an EEG, it is responsible, as you mentioned, for physical restoration, growth hormone, muscle and tissue regeneration take place. So your body is physically healing. If you're recovering from a knee operation, if you've gone for a long run, if you built a deck, that's when your body physically repairs itself. So when I'm working with the Ottawa Senators or different athletic organizations, ensuring that they get that deep quality slow wave sleep is absolutely vital for their physical restoration. The REM sleep is responsible more for the cognitive restoration. Now, if you were to look at different sleep cycles, the amount of time that we spend in each one of those stages varies over time based on what your age is. But ultimately, to kind of define slow wave sleep, as I just did, it happens more so at the beginning of the night, the first kind of half of the night, if you wanted to look at it. You are touching on it every 90 minutes, but ultimately that deep restorative sleep takes place at the beginning of the evening. Then what happens as you go into your REM sleep in the back half? REM sleep, as you mentioned already, is responsible for that emotional regulation. It's our cognitive horsepower. Memory consolidation takes place, how we process information. So if you're in meetings at the beginning of the week and, now it's Thursday, Friday, and you're trying to recall some of that information, the reason why you might not be able to do so is because memory consolidation takes place during our REM sleep. And your ability to recall that information is going to be impacted if you're not achieving enough on a nightly basis. And there are a variety of different reasons that we can touch on, sleep apnea being one of the biggest ones. I think it's really cool and timely to touch on this, though. And what I love about sleep and about healthcare in general, as we kind of talked before it started here, we have to evolve, we have to innovate, we have to create. But lots of new research is still coming out, again, being a relatively new field. And what they've discovered now is that dream sleep, or REM sleep, rapid eye movement, while it is responsible for that cognitive restoration, they're looking to see what the byproduct, the dream itself, does that have any value other than just, fireworks while you're sleeping? You're thinking you're Jason Bourne, or it's entertainment value. So Matt Walker actually described it quite well. He said, if you look at the light bulb was designed to provide light. But a byproduct of that was heat, right? It was never designed to provide heat. Light and light exposure was obviously what it was designed to do. So apply that to REM sleep. REM sleep is that cognitive restoration, it's emotional regulation, it's memory consolidation. But do the dreams actually, are the dream being the byproduct, does that serve any sort of purpose? And what they've noticed now through doing different MRIs, there's areas of the brain that are active that are responsible for processing trauma. And that is lit up during REM sleep. Now, what it does, and they're still doing continuing research on this, and what they're starting to claim is that the dreams are actually helping you process traumatic events. It's not removing the actual event from your memory. It's disassociating that emotional response that you feel from that traumatic event. So if there's been a death in the family, as we talked with Canadian Armed Forces, if you're getting a lot of REM sleep and you're looking to what those dreams are doing, the dreams are now kind of taking the sharp edges off of those emotional responses that we're having. So in my world, I think that's super cool. The fact that we can actually dig deep and realize that the dreams are actually serving a purpose as well, not just the actual physiological state of rapid eye movement sleep.
Okay, I'm a little bit confused on one thing though. Maybe you can explain this to me. So I've worked a lot with veterans before, and they have nightmares, so they want to eliminate their nightmares.
Mhm.
But wouldn't they be having their nightmares during REM sleep?
For sure, for sure.
Okay.
So there's a difference between the two. There are night terrors, and those happen outside of our REM sleep, but those are more associated with our youth and our pediatric population. Nightmares absolutely occur during our REM sleep. So the kind of distinguishing factor here is everybody goes into their REM sleep, but what you're actually dreaming about is that actually allowing you to disassociate from the emotional response. You're kind of disconnecting the two, so you're able to process those traumatic events further down the line. You're not removing REM sleep altogether. What I was trying to kind of point out is the dreams actually serve a purpose other than just the cognitive kind of restoration. Now, if you wanted to remove REM sleep altogether, you'd be looking at a pharmacy kind of intervention, looking to implement some drugs that would suppress REM sleep so that they're not actually having those vivid nightmares that are coming through. Two different kind of distinguishing factors there.
Yeah. So, I guess that's difficult to treat. And I'm not sure if you can, talk about treatment in terms of veterans in particular. But, a lot of veterans, they use cannabis, particularly THC, because CBD won't, reduce your REM sleep. There's actually even some evidence that it may even increase it to some degree, to a small degree anyway. But THC can reduce your REM sleep. And so, that's why they're saying that, they don't get nightmares when they use the THC, which would be beneficial. But then on the flip side of that, if they're not getting the REM sleep, they're not processing their emotions. So how do you, go about treating someone when you want them to not get nightmares, but you also want them to get their REM sleep?
Yeah, I think you have to kind of be careful here on what you're trying to, what you're really trying to solve, what problem you're trying to solve. I don't look to any sort of therapeutic intervention with regards to working with combat veterans. I'm more of the diagnostic test. I can kind of give you what the data shows. But yeah, a very kind of balanced approach there. And I understand what you're saying. The REM sleep is so vital for your cognitive restoration and the memory consolidation, all those different pieces we touched on. So it is crucial to their overall sleep cycle. But I guess I guess you'd probably look at the severity of the nightmares, the frequency of the nightmares, how disruptive it is to that particular patient, that particular veteran. And again, it kind of gets out of my scope of practice there. You'd probably look at an overall picture as well. But before you start looking at suppressing or removing any pieces, I think a full kind of evaluation and markup should be kind of done on that particular patient. And again, kind of outside my scope. So I want to speak to what I'm good at.
No, I understand. Again, I know that you mentioned that you work with veterans, and I work with veterans as well. So, it is something that, is a case by case basis, and, we can't really have that, too much of a, reductionist, sort of approach to that, in terms of like, what, that there's some specific thing that we should do every single time. But, my thoughts initially would be, if someone's having them every night and it's really, interfering with their overall function in life, then, maybe you get them on some THC or something to reduce the REM sleep initially. But over time, as, hopefully things heal, and hopefully they can heal through things like, therapy or whatever it is that they find is, helpful for, improving their overall PTSD symptoms, then maybe you can reduce the dose of, say, the THC or the medical intervention that you're using to reduce that REM sleep, so that they, don't get nightmares and then get back to getting, regular REM sleep without nightmares. But again, case by case, basis. But let's move on to sleep apnea. I think that's kind of, your bread and butter sort of, and, what, sleep efficiency is really all about, sleep apnea. So, what are the first signs of sleep apnea, first of all?
Yeah. And we can kind of bring back those different sleep stages and the importance of REM and maybe not getting to it due to some of these different sleep disorders, sleep apnea being the biggest one and the most prevalent. So to answer your question, chronic snoring would be the first one right out the gate. It can be benign and simply just irritating because somebody else is in the blast radius of your snoring, but it can be definitely a warning sign. Morning headaches would be another one due to oxygen deprivation that's happening potentially and regularly throughout the course of the night. Poor memory and concentration. We talked about REM sleep, how that's impacted as well. Looking at excessive daytime sleepiness. So how tired and fatigued we are throughout the course of the daytime. Multiple awakenings throughout the course of the night, gasping for air. These are kind of your classic symptoms. So what's ultimately happening here is it's muscle tissues in the upper airway that are causing partial or complete blocks. When that happens, your oxygen levels go down, your carbon goes up, your brain sends a signal to start breathing again. And depending on the frequency of these events, it can be incredibly disruptive and ultimately quite dangerous if it's left untreated. So sleep apnea is broken down into mild, moderate, and severe. And depending on how many events you have on an hourly basis, called an AHI, an apnea-hypopnea index, it kind of puts you in one of those buckets. So mild events would be anything between 5 to 15 events per hour. Anything between 15 to 30 events per hour would be deemed a moderate apneic. And then anything over 30 events per hour would be severe. I have patients that stop breathing over 100 times per hour. Their upper airway closes. They have a massive apnea that can last 60 seconds, 70 seconds, even a minute and a half. They take a couple recovery breaths, and then they have another massive pause all night long. And typically, you can imagine when you have these elongated pauses in your breathing, your oxygen levels go down substantially. When your oxygen levels go down, sometimes they're hitting 70% and even below, which are these severe oxygen desaturations, which then increase the risk of heart attack, stroke, congestive heart failure. When we go into our deep sleep, which we talked about a little bit earlier, that's the point in the night in our slow wave sleep where our blood pressure drops to the lowest level. It's when our heart rate decreases to the lowest level, and it allows our heart to rest and recover. So what can be the biggest kind of thief in the night is apnea that's robbing you from getting to these deeper, more restorative stages. Again, you're trying to go through these 90-minute cycles, but these respiratory events, depending on the frequency, can really be preventing you from getting to and staying in those stages of sleep that really afford those symptomatic improvements.
So the big thing with sleep apnea, outside of, the airway, which obviously can be incredibly dangerous, but the thing that's most commonly, affecting people who have sleep apnea is they're not getting into REM sleep and they're not getting into deep sleep because they keep essentially, waking up because of the lack of oxygen and that they need to start, breathing differently again. And so a lot of people then, I guess, with sleep apnea, you mentioned that, some, symptoms before, such as, morning headaches, but obviously like daytime sleepiness, not feeling restored overall, emotional dysregulation, basically all the things that come along with not getting REM sleep or deep sleep is what they would experience.
Some people actually have what they call REM-related OSA. So they don't have any type of sleep apnea occurring whatsoever until they go into their REM sleep. So when you go into your REM sleep, there's a muscle atonia that takes over the body. It prevents you from acting out in your dreams. Again, so you're not, punching, kicking, acting out a Tom Cruise action sequence. That's the point in the night when your muscle tissues and your upper airway become the most relaxed. So some people are breathing totally fine in every other stage 1, stage 2, deep sleep or slow wave. And then as soon as they go into the REM sleep, that muscle atonia takes over and they actually get kicked out almost immediately because the upper airway closes. So these people aren't even achieving any REM sleep. It's actually called, as I said, REM-related obstructive sleep apnea. So these people aren't acquiring any across the course of the night. And then, of course, feeling all of the impact of that lack of one particular sleep stage. So, the first kind of step in the process here is getting a diagnostic. We have to get away from this preconceived notion that apnea is just a heavy person problem. It's not. We have, myself, I have sleep apnea. I'm 190 pounds. I'm 6'1". I'm 47. I stop breathing 27, 28 times an hour, which is that high end of moderate. Once upon a time, if you rewind to the 90s or something like that, this was looked upon as just a heavy person problem. It's simply not true. The prevalence of sleep apnea, I think, is the stats now are saying 1 in 4 Canadians have or are at risk of getting sleep apnea as they progressively age. And sometimes it's to do with the tongue, the tonsils, or the uvula. I use this as an example a little while ago when we had our conversation before. I have some of the athletes that come through, and to look at them, these are elite athletes that are performing at the highest level. And to look at them, they've got, bodies that are, just absolutely shredded. And you would never imagine that some of the top NHL players, or I mean, football players, a little bit different. They got a really large neck circumference. That would be another marker as well. If you have a large neck circumference, the prevalence of sleep apnea can go up. But you've got elite athletes that are moderate and severe apneics, even though if they could be off the body of a Men's Health magazine. So, looking at what those symptoms are, listening to your body is incredibly crucial, And what the scary part is a lot of people refuse to get tested because they may think it's an automatic diagnosis to a CPAP machine, and that's not necessarily the case. There are other options.
And so in terms of the anatomy, you mentioned it could be like a large uvula, I guess. And for people who don't know, that's the thing, the structure that like hangs down in your mouth that you can see, when someone opens their mouth. Large tonsils, is that also another risk factor?
Yeah.
And then what about sinus obstruction?
Typically, no. The obstructions are normally happening in the upper airway here. So, I mean, deviated septums can obviously cause issues with breathing and things like that. But ultimately, obstructive sleep apnea is happening. Muscle tissues in that upper airway are what are causing the obstructions or partial obstruction. So it doesn't necessarily have to be a complete pause in your breathing. Apnea is defined as a cessation of breathing for 10 seconds or longer. But there are smaller, less significant events, but it can still cause a lot of sleep fragmentation. For instance, hypopneas are reductions in airflow. That's that H in AHI that cause a lot of sleep fragmentation, and they're associated with oxygen desaturations as well. There are other events such as what they call RERAs, respiratory effort related arousals. So these are smaller little respiratory events that are occurring that maybe don't have the same impact on your oxygen levels, and thank goodness not impacting your cardiovascular system, but it still can cause a lot of sleep fragmentation throughout the course of the night. And again, preventing you from hitting those deeper, more restorative stages as well.
Okay. And just chatting about, the anatomy one more time and, maybe what needs to be done structurally, like maybe there's some kind of, surgery, like, you mentioned the deviated septum and, how that's maybe not as big of an issue as, a large uvula or large tonsils. But septoplasties, like many people who get these who have deviated septums say that it makes, a world of difference overall and that they can breathe significantly better. Would that potentially reduce your sleep apnea if you did get, a successful septoplasty?
It could. It depends on, again, like the severity of the apnea as well. How bad was the person, particularly to begin with? In certain circumstances, there's no kind of quick fix. There is surgery that you can actually do. It's a uvuloplasty where they actually remove some of the, I think the acronym is UPPP. They remove some of the excessive tissues around the upper airway, creating a larger area because, again, that tongue can be enlarged. Some people have an enlarged tongue where the thickness is disproportionate to the size of the airway. But ultimately here, the surgeries that you potentially have done aren't always the answer to the actual. It's not a complete 100% success rate, so to speak, I guess is what I'm trying to say here. So, the CPAP therapy, probably the most effective therapy and less invasive, of course, to the point where you're not requiring surgery to do it. There are oral appliances you can work with as well. So, yeah, I mean, consulting with the family physician, obviously, to start, but then a referral to an ear, nose, and throat specialist to be looking a deep dive to see if you're going to be that particular successful candidate. It's not as though, getting one specific test done is going to remove all the events. While it has had some success rates with the upper airway surgeries that have occurred to remove some of those excessive tissues. I have a friend that did it. They're quite painful. And he went from a severe apneic down to a moderate apneic. So we've reduced the amount of events that are occurring, but he's still suffering. Those daytime fatigue levels are still there, and might be a good kind of segue into CPAP and how that is really a game changer for a lot of people, despite the negative.
And I do want to chat about CPAP, but one thing you mentioned there earlier too is like, large necks, and we're talking about large structures. So, do you ever get guys who are, well, I guess you said like, that you have guys who look like, they could be on the cover of a Men's Health magazine, but just guys who work out a lot. And, certainly, even if you don't do any direct neck training, but a lot of people do direct neck training just to kind of prevent injury and stuff like that. Like, is there any risk in like increasing your risk of sleep apnea if you just, get a big neck through hypertrophy, like just through training? Or is it mostly just through people having, the bad luck of genetics or just being overweight? Or can you actually get sleep apnea just by being basically like a jack dude who has a big neck?
Again, it's probably a few different things to look at. There's obviously a genetic component to it as well. Typically speaking, it's excessive tissue around the neck area. And if your neck circumference is larger than 17 inches for males, 16 inches for females, then the prevalence actually goes up. I think the stats for, like, if you look at some of the linebackers in the NFL, something like 30 or 35% of them all have sleep apnea due to these large neck circumferences. So what ends up happening is it's more weight on the upper airway, especially from a positional standpoint. So when they go to bed at night, that excessive tissue around the neck area places or puts extra weight on the upper airway. Gravity kind of comes into play and causes the obstructions to happen. So again, I think that there's a strong possibility that people who just have large necks in general, from just being, you said, being jack dudes or whatever, that there is a strong chance that it could be there. Again, I get thrown curveballs all the time. These people that you would assume would never, ever, ever be in a situation that they're in from a diagnostic perspective and being that severe. And I get fooled. And then I have patients that are 120 pounds, and those ones have been some of the worst I've ever seen. So it's really, nobody's exempt. I really, obviously being the owner of Sleep Efficency and a diagnostic home-based sleep testing, I think everybody should get a sleep test. But, the home sleep testing device is now shine a spotlight on a variety of other different things as well. We look at sleep optimization techniques with our patients. Every patient that comes through, we offer a personal one-on-one post-test analysis where we comb through a 5-page report, and we're able to actually look at different areas because, some people say, oh, I have no problem falling asleep. I fall asleep in 2 minutes. Well, that's not necessarily a good thing. It means that you're probably carrying a sleep debt, right? You're so tired that you're not getting enough, or at least the quality isn't there. So
Yeah,
there's a big piece in sleep optimization.
it's interesting that you say that, and just before we get into CPAP and the meat and potatoes of that, I do have an Aura ring, and we chat about that when I had my consultation with you after, my sleep efficiency test. And I noticed that, like, if I fall asleep within 1 or 2 minutes, it kind of puts me in I'm not sure what the Aura really calls it, but I'm not in the optimal zone. I might be in like the red or the orange zone, whatever, zone that particular is called in. So if you fall asleep too quickly, I guess it's not good, because maybe it shows that you are in sleep debt kind of thing, as you mentioned. So I think the optimal time is around 10 or 15 minutes. I've had so many friends, close friends, and, people I know. I think, you've probably watched podcasts with people too, where, they said that, like, the best thing they've ever done is get a CPAP machine. And, they notice improvements. Some people notice improvements on the very first night. And then certainly, it does become better, gradually over time. But, that does seem to be, the gold standard by far in treating sleep apnea. So, why is it so effective, compared to, some other treatments? And certainly we will talk about some other treatments as well. But why is CPAP machine the gold standard?
I think just for the therapeutic success rate that it has. So what it actually does in its efficacy, it stands for continuous positive airway pressure. And again, the technology has advanced tremendously since, let's say, the 80s to where we are today. But ultimately what it does is it acts as a pneumatic splint for the upper airway, that those muscle tissues that were either partially or completely closing are now remaining open. So through a predetermined amount of air being blown through, not oxygen, just air, ambient air from inside the bedroom, it keeps that upper airway open, removing those respiratory vents. It allows you to hit those deeper stages of sleep, keeps your oxygen levels up, and essentially is an unbelievable and a game changer for many people. Now, one thing we should say, while it is the most effective, it also has only about a 50% compliance rate long term, which is not very good, a bit of a coin flip. So as you can imagine, a lot of people don't like the idea of having to sleep an entire night with a mask on their face. It's not sexy in the bedroom. They've got to cart it around with them. There's an acclimatization period where, they're struggling. It's some people, they're not sleeping with it as much as they should be. Therefore, they're not reaping the benefits of what the CPAP therapy actually offers. And therefore, it becomes this double negative, right? They're trying to sleep with it all night long, but they're maybe only getting a couple hours of sleep because it's too invasive, too disruptive, and therefore they kind of fall off. So some people will use it for a few weeks, some people will use it for a couple months. I think if you can initially get over that hurdle of maybe, the 2 week to 1 month of usage, and you can actually feel the benefits, everything starts trending in a better direction. Now, typically speaking as well, the more severe you are, the faster you respond to the therapy and the more benefit you will feel from the therapy. So most people only go on CPAP therapy if they're deemed a moderate or a severe apneic. So anybody with an AHI of, let's say, 15 or higher, if we were going to ballpark it, there's extenuating circumstances for everybody, but typically the moderate or severe range. Those people who are put on CPAP who are lower, let's say with an AHI in the mild range of maybe only 7 or 8 events, and some people do, some doctors will prescribe it for symptomatic improvements. There's a few things going on here, so let's try it out. They have a hard time because they don't necessarily reap the benefits. Their sleep wasn't that busted to begin with. They're having a hard time noticing the benefits. I used to work for a couple CPAP companies when I first started, and I used to tell patients, they'd come in week after week, and they'd say, you know what, I'm really not noticing a difference. And these were the moderate and the severe apneics. And I would say, okay, well, just don't sleep with it for a night. Take a couple nights off and let's see. And they come back and they go, Jesus, that was unbelievable. I had no idea the benefits it was giving me because it's been somewhat incremental over time. And then all of a sudden they take a break from it and all of those symptoms come rushing back. All of that daytime fatigue, all of that fog. It's almost like when you're driving a vehicle and there's fog on the windshield, that's what you're like pre-CPAP if you're a severe apneic. You take a towel and wipe that fog off the windshield, there's clarity that comes through from using the therapy. You go off the therapy, and all of a sudden that comes back. Keep in mind, it's not a cure, it's a treatment.
And in terms of like overall metrics that people would see, so say if someone has moderate or severe, we'll kind of leave mild out of the question for right now. What kind of improvements would they see in total sleep time, deep sleep, and REM sleep, just in terms of metrics? And obviously, we'll talk about symptom improvement too. But which may be, obvious at this point if you listen to the whole podcast, but, in terms of like the actual metrics that people would see, what kind of improvements do they see, particularly in total and deep and REM?
Mm-hmm. So the nice thing about our tests as well is we can see what those stats are prior to actually any sort of therapeutic intervention. And these types of people who have moderate and severe apneics, these patients, they're probably only getting about 10% of maybe the 20% of deep sleep that they should be getting on that continuous sleep cycle. Same thing with the REM sleep. They're decreased substantially because the muscle tissues are kicking them out. So when you implement CPAP therapy, especially for those severe candidates, usually, depending on your age as well, we need to be kind of specific here. You should be getting out of that sleep cycle of 90 minutes, probably about 20 to 25 minutes of deep sleep and maybe about 20%, or I shouldn't say 20 minutes, 20% of your deep sleep and 20% REM sleep as well in the entire 90 minutes. So when the therapeutic intervention comes in, we see a boost in all of these sleep stages. When I worked in the sleep lab, it was super cool because we'd have patients that would come through that had never been on CPAP before. And if you look at their original PSG, which is their initial hospital-based sleep test, you can see that they maybe only had 2 or 3% of REM sleep throughout the course of their night. Now, all of a sudden, you implement CPAP therapy. It's that positive airway pressure. And it's called a titration study. So you increase the amount of air being blown through the mask till they get to an optimal pressure setting where we've removed those respiratory events. Now, all of a sudden, their body gets into REM sleep, which they've probably been starved for the last 5, 10, 15 years. And their body goes, what the hell is this? And we call them REM rebounders in the sleep lab. That's kind of the term we use. We're like, this person is going into the REM sleep. Not only are they hitting the REM sleep, they're staying there and they're soaking it up and they're soaking it up and they go out of it briefly and come back into it again because their body has been starved from it for so long. So now they get to that stage of sleep that they're able to actually sit and soak it up. They come out in the morning almost in tears and they look at me and say, I don't know what the hell just happened. I have not dreamt like that in years. And truthfully, it doesn't just seem like that to them. They really haven't. So again, the improvements in REM sleep, astronomical. As I did mention, some people don't even get any because they're a REM-related obstructive sleep apnea case. And the slow wave sleep as well, that physical restoration they would start feeling. And what I see often here, Mike, is everything starts trending in a better direction. So when you go to sleep at night, I use this analogy every now and again, how you plug your phone and that phone's got 100% battery power throughout the course of the day. You can do 1,000 things on it. People who have severe sleep apnea are waking up with an internal battery of maybe only 50%. So despite their best efforts, they may want to get to, the gym after work, get their 10,000 steps in to try and lose that weight. but through no fault of their own, due to these severe apneic events, they don't have the energy levels to do so. In comes CPAP therapy. Now they've got a full battery charge where they're actually able to get out, join the gym, lose the weight. It's a positive feedback loop now where everything starts trending in the right direction. And some people come off CPAP altogether, depending if it's been, a substantial weight loss. It is a fantastic therapy, providing you can acclimatize to wearing it.
And just to get into, the numbers just a little bit more, Andrew. So, we talked about the 90-minute sleep cycles, and we talked also to how, you will get more deep sleep in the first half of the night and more REM sleep in the second half of the night. And, I've even heard Andrew Huberman and Matt Walker say, if you want to get more REM sleep, just try and sleep an extra half hour. And sometimes, you will get more REM sleep just that way because, by virtue of sleeping more later, you will get more REM sleep because of, what we just discussed. You get more REM sleep later in the night. But in terms of, the sleep cycles, like say if someone, sets about 7.5 hours or so to sleep, maybe some people a little bit more. So if you're going through about, 20 minutes of each per cycle, REM and deep, so that would come out to about 1 hour and 40 minutes of each. And so would that be the overall target that you would have for people? And then my other question with that would be, when someone has moderate or severe and they start using the CPAP machine, and I know you talked a little bit about percentage, but just in sort of, total numbers, like what do they usually see in terms of improvements, provided again that they are in the 50% who are compliant with the CPAP machine?
So when we talk about time spent in each sleep stage, it's important to look at what the age of the patient is specifically as well, because something we haven't talked about this yet, but I'll just touch on it very briefly. There's something called sleep architecture. And as we age, the amount of time that we spend in deep sleep and REM sleep starts to diminish just through a natural physiological process. So seniors, for instance, already, just regardless of if they don't have any respiratory disturbances, that deep sleep is slowly diminishing over time. They spend less time in those stages of sleep, and there's more frequent awakenings throughout the course of the night because of those lighter stages. Same thing with REM sleep. Now, if we're talking about the general adult population, and let's say, 18, maybe up to, let's say, 60 or something like that, then yeah, you should be pretty much getting about that 20 to 25% of that sleep cycle continuously throughout the course of the night. If you want to extend your sleep time, I think was that way you were kind of leading to as well, to be able to acquire a bit more at the back end?
Yeah, I just heard, Andrew Huberman and Matt Walker, they discussed that, one way to get more REM sleep is possibly just to spend essentially like, more time in bed. And because of that, you will potentially get a little bit more REM sleep. So if you get up at, if you're used to getting up at 6:30, if you get up at 7 o'clock, like maybe between 6:30 and 7 o'clock, you will get, a chunk of REM sleep. Again, not saying this is, definitely going to happen, but I guess some of the logic is there.
And I think it's important to touch on, how continuity is king. Despite the fact, moving yourself an extra 30 minutes or things like that, I would be careful on what you're doing specifically and not changing it all of the time. Maybe if you need an extra 30 minutes, keep that continuity. Our body's sleep cycles tailor to very specific hours. And if you are changing your bedtime and your rise time, those sleep cycles will shift. Normally, if you're keeping the same bedtime and rise time, you, in theory, should be really closing out with a REM period just before you wake up. And it will naturally pull you out of that stage and allow you to kind of come back into stage one, which will then allow you to kind of wake up feeling refreshed. If you're going to bed, let's say at 1 o'clock in the morning, you're sleeping till 9, and then the next night you're going to bed at 11 p.m. or 10 p.m. because you're tired and you're getting up at 6, the body craves routine. The body wants to be structured. And if we're constantly shifting our bedtime and our rise time, what can happen, Mike, is if we're pulling ourselves out of a deep stage of sleep, out of our slow wave sleep, that can cause something called street sleep inertia, which is characterized by a sleep drunkenness or a sleep grogginess. So, sometimes you can maybe, and this is you and I felt it myself, you wake up in the morning and there's certain days where you're like, hey, I got my 7 or 8 hours here, but I just feel like I can't get that hamster on the wheel. I'm not firing. And other days, by the time you get out of the shower, 10 minutes, you're like, I'm ready to roll today. I'm ready to dominate my day and I'm feeling really good. And that can be because of the fact that you actually woke up out of a nice later stage and you weren't ripped out of a sleep stage you weren't able to finish. Hence why, snoozing the alarm clock is so bad for you. If you're somebody who sets the alarm clock and you're hitting it 3 or 4 times across the period of half an hour, 45 minutes, you're playing havoc with those sleep cycles. You're tricking your body. It's trying to go back into a deep stage of sleep, and now you're ripping it out again. Same thing with napping in the afternoon. A nap can be phenomenal and an amazing tool to have in your toolbox, but the duration of the nap is critical as well. You only want to keep that nap to maybe 20 or 30 minutes, because if you actually extend it to 45 minutes or an hour, you're going to get into your deep, slow wave sleep. And unless you can complete that 90-minute cycle, you're going to wake up feeling worse again than when you actually lay down. Has that happened to you? You will lie down for a nap maybe in the afternoon and you're like, man, I feel actually worse than when I woke up. That's because you might have gone into that deep sleep.
Yeah, fortunately, I'm not a napper, so I don't have that issue. But yeah, just before we move on, maybe to other treatments as well, like again, this is just aura data, but they say that in terms of deep sleep, you want to get basically 15 to 20%, or about an hour to an hour and a half per night. REM sleep, they give a significantly bigger range. They're giving 5 to 50%, but try to get about an hour and a half. So it seems like if you can get, two, like on the very, very low end, but really 3 hours of sleep between deep and REM, you'll probably be feeling pretty good overall. And then, again, just coming back to the numbers of like the 90-minute sleep cycle, if you go through 5 of those, 7.5 hours, then you're getting an hour and 40 minutes of each. So it seems like, 3 hours is probably around like the golden number that you want to get in terms of REM and deep overall. And so, again, before we move on to maybe some other sleep hacks, do you feel like that's the goal for a lot of people? And are there people who have been moderate or severe sleep apneics that you've seen that have used, whether it's CPAP or something else, and then you see them move from, say, I don't know, 30 or 45 minutes of those sleep stages of REM and deep, and then they move up to an hour and a half, and that's where they really seem the symptom improvement overall?
Yes, fully. And I think the numbers you've thrown around there are relatively accurate. Again, factoring a variety of other things as well.
Age, you said, yeah, I understand.
Medications can kind of come into play there as well.
Big
But yeah,
time.
ultimately, the CPAP therapy and that intervention will allow you to increase all of those stages of sleep, which is absolutely critical. One thing I will say here as well is we have to be, and I know data is fantastic and it's what drives the whole field forward. But from a personal experience and from a patient perspective, we have to be careful on what we're tracking, and we live in that day and age now where everything's tracking. You've got your Aura Ring on, and I embrace the whole technology and the whole kind of, let's try and optimize it. There's actually, as per the American Academy of Sleep Medicine, they've actually come out with a new sleep disorder called Ortho somnia. And the irony here is it's people that are having difficulty falling asleep and staying asleep due to obsessing over optimizing their sleep overall. So they're
Yes.
obsessing over those numbers. How much REM sleep should I be getting? How much slow wave sleep should I be getting? And in turn, they're having problems falling asleep and staying asleep because of that obsession. And it's usually due to sleep tracking apps. So to kind of like put it all together, without question, your body will naturally regulate and achieve those stages once we've removed any sort of sleep disorder that can be impacting the deep sleep and your REM sleep. Once we've identified the sleep disorders, we've treated the sleep disorders, your body will naturally achieve these. And, there should be no substitute for a natural night's sleep. People look at melatonin or they look at taking different supplements. While they all have their place, your body wants to be as natural as possible. So again, crunching the data and the numbers is great, but I would be careful for your listeners, be careful how much you're actually tracking. You don't want it to turn into an obsession, and we're creatures of
I
habit,
agree.
right? It's just something. And again, orthosomnia, the irony is dripping from the bedroom walls.
Yeah, and I think that before there were trackers and that kind of thing, people just get apprehensive about sleep. They'll watch something or learn something from Matt Walker, who will say, if you don't get your sleep, you're going to get dementia and that kind of thing, and then that gives them anxiety before going to sleep. And so I think that kind of falls into the same category as what you were just talking about with that new sleep disorder. But I know we only have maybe 10 minutes left or so, and I do want to cover, a couple more things. So, we talked about the CPAP machine in terms of how people can be in that 50%. Like, what can people do, Andrew, so that they are in that 50%? And I know that we talked a little bit about, in my particular interview with you, post sleep efficiency, that wearing it sometimes like before bed for 30 minutes, can sometimes be helpful, because then you're not getting into bed and just putting it on, which is great. Obviously, too, you do have to just sort of use a little bit of willpower and think about how beneficial this this machine can be in terms of improving your sleep and your overall quality of life. And thinking about that, again, not obsessing, but just understanding that if you get through the difficult part, you will certainly see rewards. Almost like the same thing with like weight loss. Like, you're not going to lose 30 pounds overnight. It's just going to take some time. And so, eventually, once you get used to it, you will see some of the rewards. But what are the things that you see in terms of people who stay compliant and people who do not stay compliant?
Yeah, it's a good question. I think the first step is your attitude going into it. We break down with every patient that comes through. Here are the benefits. This is what you're going to actually see happen. Education is critical. If you let them know that this is going to be truly a game changer, and how quality sleep is responsible for our physical, mental, emotional health, it's going to allow you to be a better husband and wife. It's going to allow you to be a better father, a better coworker. It's going to allow you to operate at peak performance. If you hit them with all of the education on what a sweeping change it's going to be, I think the first step in the process is really letting them know that, when I have a severe apneic that comes through, I tell them right out the gate, this is a good day for you. I've just told you have severe sleep apnea, but look at it, this is a positive. We're going to make a massive change to your overall quality of life. So the messaging going forward and how you hit them with it, I think, is critical and key. I would say the second piece here is making sure that you're aligning yourself with a reputable CPAP company. Somebody that's, you're not just going to a customer service rep in a front desk counter where maybe it's somebody's that's got their summer job. Go to a company that's reputable. I have a great relationship with a company called Medigas. They're right across Canada, but they all have respiratory therapists that are working with you. So these are RTs with designation who have the education and the dedication to make sure that you succeed. And it's not just a sale of a CPAP machine for you. They will take time fitting. Let's say the mask is your first kind of step in the process. A lot of the different CPAP machines are somewhat similar. There are two main companies, kind of like Nike and Adidas. There's ResMed and there's Philips. And there isn't a lot of choice in that space, which exposes a bit of a risk when you've got two people owning the market share. Philips actually had a bit of a recall and a whole bunch had to go back. But ultimately, the CPAP therapy is going to be the same in its therapeutic approach and its efficacy. But the masks can change drastically and different for every person. The same mask that fits my face comfortably isn't going to fit yours. It's not going to fit the guy down the street. There are some masks that are just nasal masks. You have to breathe through your nose only, but they're very slim, almost like an oxygen cannula. And, they're a lot easier to acclimatize to for the patient because it's less material on your face. Now, the one caveat there is a lot of people are mouth breathers. And if their jaw drops open, that air is escaping. Yeah, well, I think we had a conversation about that. But there are, again, being a billion-dollar industry, accessories that you can buy, like a chin strap that takes the slack out of the mouth itself and keeps it closed. Your mouth isn't trying to be forced open at night. It's just it becomes too relaxed. So I would say, first things, pick a quality provider, spend some time acclimatizing to the mask. And any CPAP company should allow you to take the mask home, sleep with it for a couple nights, maybe swap that out. If they're a company that truly wants you to succeed, they should be spending the time at the front end. And just like anything else, Mike, it's your return on investment. The more you invest into the therapy, the more benefit you will feel at the back end. So again, the target being maybe a 4-hour window to start. If you can get your usage with the mask up and over 4 hours, your body will start to reap some of those benefits. Improved alertness, better sleep quality. The therapeutic intervention and the different type of mask that you're actually using is going to play a significant role in the success itself. So ultimately, spending that time at the front end. You had mentioned different acclimatization techniques. and from what you're using throughout the course of the night and prior to. So sitting at with the mask on at the beginning of the night, where you can actually sit and maybe watch a bit of television and kind of get used to the breathing, the inspiration and exhalation. It's going to allow you to kind of adjust to wearing the mask and not kind of feel like such a strange and kind of awkward kind of sensation. When you breathe out with CPAP, there's a bit of resistance, and that's what some of the biggest challenges are. Is your expiration, right? There's a constant flow of air being pushed in. So, to summarize all of it, essentially, you've got CPAP therapy. The more you invest in the actual time, I think the benefits that you'll feel at the back end will really outweigh the annoyance factor of having to put it on every night.
And then one thing too, I think that, and I talked about this in my interview with you is, my recommendation was between 6 to 14, units, and, which was, maybe a little bit on the higher side because, my apnea index was 38, which was quite high in the severe range. And so there's a function where you can, go from 0, say, to 4, where it just kind of revs up. And I sort of tried to be a hero on the first night and just go, right up to 6, which, didn't really work out for me too well. And I have found that it was significantly easier if you use that auto function where, it just starts out at, 0 to 1 and then revs up a little bit. And then, I'll just set it just to like 4 to 6 for right now. Or, maybe eventually I'll get, to that 8, 10, 16 area, hopefully eventually where I need to be, that's because that's what my prescription is. But I think it is, helpful for people to know, like, just start out with like the lightest pressure at first, and then you get used to that. And then, eventually, go up to your, prescription level.
So the CPAP machines have evolved substantially again over time, where a lot of people are being put on what they call auto CPAP now. So CPAP is that continuous positive airway pressure. Your pressure is 13, mine is 9. What they have evolved to now is what they call an auto CPAP, and kind of your prescription would be 6 to 14 as a general kind of parameters. So it's bouncing between a minimum and a maximum, 6 being the minimum pressure and 14 being the maximum. And it's giving you what you need on a breath by breath basis. The CPAP machines typically start at a pressure of 4, and it will ramp up to a pressure of 6 if you need it to. So that allows you to kind of drift off to sleep. And then what happens is the CPAP machine, or the auto CPAP machine, is following, I think it's a 2-minute algorithm where it's sensing how much pressure you need on a breath by breath basis. So it will ramp up and give you the pressure you need. Let's say when you're on your back, a lot of people need a higher pressure setting when they're on their back because of that weight on the upper airway that we talked about earlier. So it'll bump you up to maybe 12 or 13. But then when you roll onto your side, it will adjust accordingly and reduce that pressure maybe down to only 6 or 7 events. So it's constantly tweaking. And this is what helps with that acclimatization and the body being able to get used to wearing the therapy. We mentioned how some people are only REM-related cases. So they may need the most minimum, most basic level of pressure. Maybe it's 6 or 5. But when they go into the REM sleep, they need a pressure of 13 or 14 because that upper airway closes. So that auto CPAP will automatically ramp you up to that therapeutic pressure to make sure that you're continuing to breathe. So again, we've said it, the technology is advancing and there's continuous improvements. We haven't got out and away from the CPAP machine because it is so effective, but at least it's not a massive machine on your bedside table that sounds like an airplane taking off every single night. The tech is advanced where it's deathly quiet. If people that are listening say, my machine is loud, it might be because, it's an older machine. Maybe you need to change the filters on it or something like that. But more often than not, it's the mask fit that's the issue. It's a air leak in the mask fit itself where mask is escaping and it's causing like a farting sound, not to sound too crude, but ultimately that's what it is, right? It's air that's escaping out of the mask. So I would look at the type of mask you're using. If you're somebody that's been using the same mask for several years, it's probably time to pony up and get another one. If it's something that you're wearing and you're breathing through every night, cleanliness is obviously a big piece of making sure that it's still a good fit.
Andrew, I hate to do this because I know we have, so many more things that I wanted to get through today. So I'm going to have you back on the show, but I do have to wrap things up here. But please tell people, where they can, a little bit more about sleep efficiency and where they can do their test if they're interested.
Absolutely. So sleepefficiency.ca, that is our website. We are physically located in Ottawa, but we ship devices right across the province, right across the country. We actually shipped a couple devices out to Iqaluit last week to Nunavut. So great opportunity for people in remote areas to access sleep testing. Patients can self-refer directly on our website. We do have physicians that use our services, cardiology clinics, pre-ops, but unfortunately, 20%, I think it is now, of Canadians don't have a family physician. So if you want to advocate on behalf of your own healthcare and you want to get a sleep test, you can fill out a referral form. We have results within 48 hours of you completing the test, and we ship the device within 24 hours. So, if somebody puts in a referral today, by this time next week, not only have we completed the test, we're actually discussing the results. So sleepefficiency.ca.
Awesome. And like I said, guys, I, did the test myself and I highly recommend it. So Andrew, thanks so much again for coming on. Like I said, I definitely want to have you back on to chat a little bit more, but that's all the time we have today. So thank you for coming on, and thank you everyone for listening. And as always, I'll be back with another episode soon.